Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I'm your host, Dr. Oneet Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts from around the globe and around all aspects of drugs and addiction. Today's episode is sponsored by AACCP, the International Academy on the Science and Impact of Cannabis. Visit their website at isaac1.org, IASIC1.org, to follow the science on marijuana. Friends, fentanyl is plaguing America. There is no safe drug supply unless it comes from a legal pharmacy. If you are around anyone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. Hello again, High Truth listeners. Get ready for a research conversation. I'm your host, Dr. Oneet Lev. Let's discuss the research it takes to get FDA approval for a new drug. New drug approval requires extensive research. Step 1, in the lab. Step 2, preclinical trials on animals to answer safety questions. Step 3, clinical research on people with placebo-controlled comparison. Step 4, FDA review. And Step 5, post-marketing continued safety monitoring. The story of rimonabant, a cannabinoid receptor drug, is interesting and provides important lessons. Rimonabant was the very first cannabinoid receptor blocker and approved to treat obesity in Europe back in 2006. The theory was that stimulating the cannabinoid receptor increases appetite. That's why Marinade, low-dose THC, is approved to treat age-wasting disease. Think of getting the munchies while using low-dose pot. So, if stimulating the CB1 receptors increases appetite, blocking those receptors should decrease appetite and work as an appetite suppressant to treat obesity. The Europeans were using rimonabant with successful weight loss. Rimonabant was submitted to the United States Food and Drug Administration, the FDA, for approval in 2005. 2 years later, the FDA came back in 2007, reviewed all the data, and stamped a big red reject on rimonabant. They acknowledged the weight loss in the treatment group, but expressed concerns about the serious adverse side effects that included depression and anxiety. A significant number of people quit taking the drug because of the neuropsychiatric side effects. There were reports of suicidal ideations in the treatment group compared to placebo, and 2 people died of suicide while under rimonabant. Side effects included cognitive issues, tachycardia, and concern about teratogenic effects. The United States refused to approve rimonabant in 2009, and then the Europeans pulled their approval as well. It may be better to be overweight than suicidal. The FDA review saved lives by not approving a drug. And with that, let's hear our question of the day.
Hello, Dr. Lev. I love working in the emergency department. I'm just getting started in my career, and every day there is something new and interesting. My name is Shay Villate, and I am a paramedic student and technician in the emergency department. I was excited to learn about your High Truths podcast. Many people utilize marijuana as a medicine. Why don't we have more evidence-based cannabis medications on the market?
Thank you, Shay, for your question. It is indeed so fun to work with you and experience the bright outlook you bring on entering the medical profession. It's infectious. You are bright and eager, and I have no doubt that you'll be very successful in your career. To answer your question, we're going to have a conversation with a cannabinoid research expert, Dr. Jacquelyn Bainbridge. She's a doctor of pharmacy and professor at the University of Colorado Anschutz Medical Campus. She conducts research on the effects of cannabinoids for various medical conditions. And to learn more about Dr. Jackie Bainbridge, check out the High Truth show notes. Dr. Jackie Bainbridge, welcome to High Truths.
How are you?
I am great, and it's great to see you again. The last time we saw each other was at the United Nations in Vienna, and that was a lot of fun and first experience kind of learning about drugs around the world.
I know it was a first experience for me as well, and it was eye-opening, I thought, and it was a ton of fun.
Yeah, and I remember you because you were wearing those great Prada shoes. It's because there was a lot of walking around, and we needed comfortable shoes, and you had them.
Yes, I do. In two colors.
In two colors. Yeah, I went. That's what I did after leaving the United Nations, is looked up Prada boots. But so, Jackie, I want to talk today about cannabinoid research, what's good research, the research that you're doing. But first, let's start by having you introduce yourself to our audience so we get to know you, besides that you wear nice Prada boots. And you go to Fashion Week.
Yes. Paris Fashion Week is a must for everyone. At least once. I used to say running a marathon should be on everybody's list, and to do it at least once. So now you can add to that list Paris Fashion Week. So just a little bit about me. So I'm a PharmD. I started out at the University of Colorado a number of years ago in critical care medicine. So I worked in the ICU for a number of years, decided when I grew up that I probably didn't want to be under somebody else making my schedule for me and not allowing me to do or participate in any type of clinical research, which I love doing because you just learn so much about a new product or a product on the market when you're looking at it very, through a microscope, really. To see how that product is actually going to perform, or their side effects, drug interactions, that sort of thing, which I love to do. So I joined I went from the hospital side to the university side, and I'm now a professor in the Department of Clinical Pharmacy and also the Department of Neurology, since that's my area of interest is neurology and also cannabis research. And I'm also the vice chair of research in the Department of Clinical Pharmacy in the Skaggs School of Pharmacy and Pharmaceutical Sciences. So that's a little bit about me, and I've actually funded my own faculty position, and I have 2 fellows currently, and I've had residents in the past and research assistants that mainly have been funded through clinical research. So I really got interested in research when I was on the hospital side, but then also on the university side, and especially when I had mouths to feed. It was a good way to do that. And also it gave young people who wanted that experience for a clinical neurology research fellowship to actually participate in that. And then they can go on with that postdoctorate training. So, and we have several clinical trials going on right now, currently with cannabis.
And we're going to get to that. Definitely want to hear about your amazing research. And interesting that you do research out of Colorado and on cannabis. Is there a coincidence there? Because Colorado is known for its cannabis.
Yeah, this is very true. And that's such an interesting point. So, right. So we were one of the first states to have medical and recreational cannabis, as you know. And it seemed like a lot of our patients in neurology would tell us that they were trying cannabis for some of their symptoms in different areas in neurology. So, and I think legalization really kind of helped a little bit with this because it made it a little easier for patients to tell practitioners what they were actually doing. Whereas prior to that, sometimes they would tell us, especially in epilepsy, But other conditions, many times they wouldn't really open up.
That's absolutely true. That's something that legalization did, is make patients more honest with their doctors. They're not like trying to hide that in general.
Right.
Yeah. So Denver is a great place for beautiful place. I was just visited recently for Johnny's Ambassadors. There was a conference there. The only problem I had is when I got my rental car, it smelled of weed, and I didn't like that.
Yeah. And that is really a problem here in the Mile High city, because everything smells like cannabis. So, and when we were in Vienna, I thought it was really nice because, just coming from Colorado, it's like, wow, the air, it doesn't smell. We don't have that, that cannabis
secondhand smoke effect.
Yeah.
There's also, again, very much an acceptance of marijuana in Colorado, in Denver, and I'm wondering if that affects your research in ways where there's pushback and any negative reporting on harms of marijuana.
That's a very interesting question. So when you talk about recruiting subjects for a clinical trial, I mean, obviously we can't have them using cannabis outside of the trial. So we're always having to look at testing prior to enrolling them into a clinical trial. So, whether or not, they're eligible or not, are they going to fall off the wagon, that sort of thing. And in most of our early studies, you actually wanted patients who had some exposure to cannabis because we didn't want them having a lot of negative adverse effects in the clinical trial. So I don't know if that quite answers your question, but just in terms of recruiting patients, it's always a challenge because you need them to abstain from what patients are actually getting from a dispensary in Colorado.
Wow, that's really interesting because we know that some people are predisposed to have negative effects from cannabis, like psychosis, and they try it once, it's like, okay, I'm never doing this again, and other people who don't, and like, oh, this is great. And I'm wondering if those studies, you get that selection bias.
Yeah. And it is a selection bias. I agree.
And what I was thinking about the pushback is, we did our institution at Scripps was part of a drug surveillance, along with different hospitals across the country to see what drugs are coming up in the emergency departments. And I noticed that University of Denver's hospital, had no marijuana. And like, how could that be? And that's because they purposely took it out of their drug screen, which I thought was very irresponsible, political versus clinical decision for hospitals and doctors not to be able to make the right diagnosis. And that's what I meant by are they trying to hide the negative effects? One way to hide it is just, we're not going to test anyone in any hospital.
Right. And that, that is true. So, and even what I recently heard is that even healthcare practitioners now are not going to have to, or they don't get in trouble if they were found to be consuming the product because of the legalization. So I think that is kind of a workaround. And I think we're also seeing that maybe in traffic accidents as well. So even though they're trying really hard to get that kind of figured out, what's realistic, just like with alcohol, how should they be testing? When should they be testing? What's positive, what's not positive, because we know it hangs around in the system. Marijuana does for a long period of time. And so what do you call a DUI kind of thing? So
yeah. Oh, wow. It's impactful what you just said. Do we want our doctors to be high when they're treating you?
Yeah.
I don't.
Or pharmacists, right?
Or pharmacists. So Shay is a new EMT student starting his career in medicine, and he has a question. That was a perfect question for you. He says that many people claim that marijuana is medicine, and why don't we have more evidence-based cannabis medications? So I thought that is a perfect question for you.
It is a perfect question. And a lot of the research that is currently being done, we have to use specific products, especially if you're at a large institution like the University of Colorado. So we can't use what people are actually getting from a dispensary. So we can't tell them to go out and bring us something. We can't test it to say, this is how much THC or CBD is in that particular product, because you can't bring it onto campus. So there's so much red tape in getting all of this research up and going. So I can tell you that with what we're doing now, so most of our supply has to come from NIDA, which is fine, but then it's a supply and demand thing. So they only have so much because they're dependent on what the University of Mississippi is growing. So the farms are growing and what product they have available at the time. Well, that's getting a little better because the FDA is now working with the NIH and NIDA and DEA to, there are several companies now that are actually able to have their product run through NIDA, and it's approved product that we could actually use at the university. So
yeah, interesting. I had a really interesting podcast I recommend for anybody with Dr. Mahmoud El Soli. He is the guy who grows the marijuana and sells it to the NIH and NIDA for testing that comes to you, and the steps that he has to go through to make sure that there's no contaminants. He basically has to sterilize the plant. The things has to go through various controls to make sure what he sells is exactly, 5, milligrams or whatever percentage he is. I even asked him, do any of the dispensaries anywhere else in the United States that's commercial go through the processes he does? And there isn't. Nowhere in America is the product like what you're using for research.
Right. And he is just such a wonderful person. And he has really been my right-hand person in all of the research that we have going on, because that's where I get our product. And he's become, a very close colleague and friend, because every time I have a hard time compounding one of his products, I just pick up the phone and say, all right, can you help me get this into solution? Or, what do you think about this or that? And his regulations are changing all the time as well. So getting more stringent and whatnot. So that's why we don't have more research.
Now, is that a problem? Or is that a good safety measure? What do you think? You think you mentioned, people can't just bring in their product and use it. Do you think that that's a good idea or a bad idea?
I think that there needs to be a balance. And so I understand, because we're administering the product on campus. So you can't just bring, a 90% THC product, right? Dabs or something, into the university, into the Clinical Trials Research Center, and have people just, just high out of their minds. So, and I get that. And you don't know if you can get that same product again. And you don't even really know what's in that product, which is the problem. So what I really like about the regulations that we currently have is I know when I get from, Mahmoud, I know that I know exactly what I'm giving our patient. I know when we're giving patients Epidiolex exactly what the patient is actually getting. And I have comfort in that, because I don't know how I would feel about giving a product that I didn't know exactly what was in it to a consumer or a patient. And then the compounder is, how would you study that? If you don't really know what's in the product, how do you know what effect you're actually getting?
Yeah. You mentioned compounding several times. What do you mean by that? How do you compound these joints for your research? What does that mean?
So, one of our clinical trials is using a volcanic vaporizer, and that uses flower material. So, from NIDA, we get a placebo or a medium grade THC product, and that's just what people normally think of as rolling into a joint. But we put it into a volcanic vaporizer, so we get around the combustibles and the health issues with smoking. But then we have a crude product that we also get from NIDA. So that kind of looks like, it's dark. It looks like an oil, but it's the consistency of like Nutella, a bit, so difficult to deal with. And I compound that into an oral solution, and generally try and mask some of the flavor of the cannabinoids that are in that crude product. So we're compounding the crude product, but then we're also separating out the flower product.
Okay. And then so you're using different ways on patients, not just smoked or vaped or oral.
Correct.
That you're giving.
Correct.
So you're when I met you, United Nations, your presentation was improving access to controlled drugs, cannabis for legitimate medical research and use. So I want to kind of talk about your presentation and share that with our audience. But first what is legitimate medical? Like, what does that mean?
So in my mind, in my interpretation of that language is really to have a known symptomatology that you're treating, and you have a product that you know exactly what's in it. So again, just having that safety measure and that confidence that you know exactly what you're giving is really what is in the product. It's not just the entire plant, but exactly what's in the product.
Right. So legitimate medical means you're having a symptom, and then you having a medicine that you know exactly what's in it and what you're taking.
Yes.
Right. So the issue is, so medical marijuana means people they feel pain, they have insomnia, and they take an edible or smoke a joint. Is that medicine? Does that meet that definition?
In my opinion, no. So
I'm setting you up.
I know. So also swinging around in that is
I should have been a lawyer.
Yes. Is that we would actually have cannabis as a legitimate product that's gone through clinical trials, so randomized controlled clinical trials, and has an FDA approved indication. So like Epidiolex, which has gone through all of those clinical trials, and we've studied it in different patient populations and looked at drug interactions and endpoints, adverse effects, that sort of thing. So in my opinion, and going back to just having somebody go to a dispensary and get something to take for pain, going back to exactly what is it that helped with the pain, and you need the clinical trials or the research to actually prove that what they were taking actually did work for the pain. So not just case reports or, a handful, a cohort.
Or how I feel, an N of one, this helps me.
And that's what we currently have. That's what most of the states are using for that basis. So medical marijuana.
Right. I feel like the word, I'm sensitive to that because there's a lot that goes into becoming a medical doctor, and for you as a pharmacist. And the word medicine has been hijacked by the cannabis industry. So everybody's like, this is my medicine. And it's like, really, you don't have any other things that, comes from a legitimate pharmacy that's treated in that way. And also the term self-medicating. I'm self-medicating. So I'm using my heroin or my fentanyl or my methamphetamine. That's not a medicine.
Right.
Yeah. All right. So, steps that we need to take to develop more real cannabis-based medicines, the kind that you as a pharmacist and me as a physician would feel comfortable uh, giving, that follows the standard of medical care. And there are some FDA-approved cannabis products. But what steps are we taking, or should we be taking, in order to make more cannabis-based medications? And maybe we should clarify, or if you explain that what cannabis medications is. That's not smoking a joint, right? It's what we traditionally think of as a medicine.
Correct. So yes, an FDA approved product with a legitimate indication is what I would call a medicine, traditional type medicine. So I like the idea that we have a plant derived product that is purified. And again, we know exactly what's in it. So when you take a teaspoon of this liquid or oral solution, you know exactly what you're getting in terms of the cannabinoid content. You know exactly what that is. Just like if you were taking a cough medicine and you would take a teaspoon of that, you know exactly what you're taking in that teaspoon. And I think that's really important. And I think that's the safe way to do business. We also have cannabis products on the market currently that are also synthetic based THC products. So, a little bit different. We've had those on the market for a number of years and, useful for nausea and vomiting.
So are you talking about like Marinol?
Yes. Sorry, Marinol.
So Marinol is pure THC, but it doesn't come from the plant. It comes from a lab. It's made synthetically.
Correct, a laboratory. So it's synthetic, a synthetic type product. So been on the market for a long period of time. So
that's great. So what are the steps that it takes to create such medications?
Well, the steps are pretty rigorous, and it's expensive too. But you have to start with preclinical data. Do you have a sense that this would work? Does it work in an animal model? Then you move into phase 1, 2, and 3 clinical trials. So you're looking at healthy controls to make sure that patients tolerate the product. And then you move to back up that phase 1 type data. You back that up with further phase 1 and phase 2. So moving now into symptomatology, treating the disease state or a condition or symptoms of a disease state. And then you move into phase 3, where you're allowing patients to have more clinical sequelae in addition to what you're treating, or more medications on board. They don't have to be de novo or on no other medication besides that particular product that you're testing. And then you could, and then they usually, a company will go to the FDA for approval, but oftentimes we'll follow that product through post-marketing surveillance into phase 4, just to see if there's a signal that there may be additional problems with a product. And that's all pharmacovigilance, essentially. So, and we follow, that's the pathway to get a drug to market. You end at phase 3, but we're always really looking for reports of adverse effects with medications, even after it's approved and on the market.
Interesting.
So it's a long journey. It's
right.
hard.
But it's meant to have safeguards for consumers, right?
Correct. So efficacy, did it do what you wanted it to do, and was it safe? So did patients tolerate it? Were there adverse events? Were there drug interactions? What do you have to look for? Who do you actually use this medication in, that sort of thing. So it really backs up safety and efficacy of our product.
One of the stories I shared with our listeners at the beginning of this podcast is a story of Rimonabant. which is a CB1 agonist that was used for weight suppression. It was approved in Europe, and why is the FDA so slow? And the American system of approving of drug is annoying and cumbersome. But it turns out that the drug was causing significant psychiatric symptoms, and the FDA put its foot down and would not approve it. There was even a suicide in the control treatment group, and eventually the Europeans backed down and took it away. So I think that's one of the lessons of being careful.
Right. I agree.
Yeah. One of the things that you had in your presentation, you talked about cannabis addiction risk. Do you want to share some of that with us?
Sure. So everyone, consumers, oftentimes don't even realize there's a difference between THC and CBD, number one. And they all think because it's a natural product, that it's safe. And we know that there are many natural products that can be lethal in the situation. So, if you look at Cedar is actually an addiction center or facility that's on our campus, on the Anschutz campus. And if you just go through the halls there, you find that many people are in there because of an addiction to cannabis. So it is a real problem. And this is even one of the places that I wonder if we're really being honest with consumers, what that risk usually is. And so the last numbers I've looked at, it looked like it was in the teens, high teens, maybe higher than that in the adolescent group, which are exactly the people you don't want to consume cannabis. But I recently heard, speaking to a physician from Brazil, that our numbers are really looking more like 30% for the addiction rate with cannabis. That's a high number. When I was working in the hospital and I had to, decide, you have a laundry list of side effects that is in the package insert of a medication, and I had to pick and choose what I was going to talk about with a patient. And my cut point was always 10%. If I see something that's 10% or higher, those are definitely things I want to mention. So, when I hear 30% or even 18%, 20%, 12%, those are really high numbers that consumers don't really understand the risks. And I think that we have so much advertising in Colorado that it makes it look, safe and it's legalized here. So isn't it safe? Like, why would my parents vote to have this legalized if it really isn't safe? So I think consumers don't get that message strong enough. And I think, I don't think that we're really good at talking about that and putting that information out there into consumers' hands, because those numbers are really, really high.
Yeah, you had a really nice graph about cannabis addiction risk. And the one point that stands out is that a daily user of cannabis has a 32% chance of addiction, which is the same thing as nicotine, as cigarettes, with the same risk. So that actually makes sense. So let's get to the specifics of the research so we can get to understand that better. So you explained, first of all, that who funds your research. You get that money from NIH. You get cannabis industry funding research?
So that's an interesting question. A lot of the current research that we have going on has been funded by the state of Colorado. So when, people were all about the medical cards, a lot of that money went back into research. So a lot of our research currently is funded by CDPHE, or the state of Colorado. And that was our autism study, which is using Epidiolex. We had a Parkinson tremor, or PD, tremor study that was an oral solution that I compounded from NIDA. And then we have a back pain study currently going on. That was a plant material using plants, the volcanic vaporizer using plant material in the volcanic vaporizer, and crossing patients over with oxycodone or placebo. And that study is kind of winding down, and we're starting another study that is using the oral solution that I'm compounding in different strengths. So we'll actually have CBD, a higher THC, and THC alone, and a placebo, and where patients will be randomized. And that's all from NIDA. So that's all from the state of Colorado. But now I do have a new clinical trial that I'm just starting with all the paperwork, but I finally did get it funded through BRC. So BRC is actually a company that is approved to distribute their products for research. So it'll be funneled through NIDA. So I'm really excited about that. And this is the first time.
Is that company a cannabis company? I don't.
Mm-hmm. It is. Well,
so they sell marijuana at dispensaries, but they're also funding your research.
Very, very big distinction. They do
okay.
that. So it's a hemp company, but they've gone through the paperwork so that they're approved to be distributed through NIDA. So it's there's like 3 or handful of companies.
So they're like Dr. L. Soley from Mississippi?
Correct. But it's hemp. So that was the distinction for the university to actually allow me to accept money from them, is because they do not sell to dispensaries. And it's more of it's a hemp product. So less than 0.3% THC. So they do not have high THC products, and they do not sell to any dispensaries or consumer models. So it's really for the research side of things.
Okay. So they're not a company that sells to dispensaries.
No.
Okay.
Very big distinction.
So tell us, what's the big distinction between product that, buying from a dispensary versus buying the NIDA NIH approved stuff for your research?
So, a big difference. So again, you know exactly what you're getting when it's coming through or funneling through NIDA dispensaries. Wild West, have no idea. It's an unregulated industry. So you really don't know exactly what you're getting. And also you don't, and you can control the product. You can control what goes into what you're giving to patients.
And by control, how many milligrams, what the potency is, what contaminants are in there.
Yes, absolutely.
So, but people who use marijuana, they don't realize that the government doesn't do that. When you buy product at the dispensary, they say, wait, but there's a label on it, there's a percentages, and yet we're talking about when you go to a dispensary, things are not regulated.
And that is so true. So and in the beginning, when we first had all these dispensaries in Colorado, you could easily get a certificate of analysis. And we would always tell our patients to make sure that they got a certificate of analysis telling you that the product has been tested, what exactly or whatever they tested for was in the product. But now we're seeing that really fall off the charts. So now it's really difficult in some dispensaries to get a true certificate of analysis. And a lot of the testing that's done is not great testing. So they're not really looking for all these heavy metals. They're not looking for some of the pesticides.
E. coli, aspergillus, all the fungals.
Absolutely. And so think if you're a patient that's immunocompromised and you're consuming those products, you're really setting yourself up for havoc and even, worse.
Right. And I don't think our patients or even doctors and consumers have no idea. They think, I don't know how many people have come to me and they have cancer and they say, I have pain. Shouldn't I use marijuana instead of opioids? Those opioids are terrible. And I have to tell them, no, I'd rather you take opioids because you're immunocompromised. You're more susceptible to getting aspergillus and other infections. And the CDC even has a warning not to use specifically, flower products in people who are immunocompromised.
Right. And that's such an important point. And consumers, again, don't understand that. It's a natural product.
So I want you to take us through one of your trials so we can kind of like get a picture of what it's like. I don't know, pick maybe the back pain one. So you've got a back pain you want to study. So what's the hypothesis?
So the back pain study, obviously, is the cannabis product comparable to an opioid, oxycodone?
Okay.
And we actually do for that trial. So money came from the state of Colorado, then getting through red tape at the university, all the hoops, all the committees, all the COMER, so the IRB, Institutional Review Board, getting through all of these committees. It actually took us 24 months to get through all of the committees and all of the approvals that we needed, writing the IND, holding the IND, so approval of the product from the FDA, and then going through the DEA to get a research Schedule 1 to administer the product or prescribe the product or cannabis. All of that just takes so long. And I actually went in as I was initially going to be the DEA 1 holder, but being a pharmacist going in as a DEA 1 researcher holder was just another story. It was too much. It was a big hassle. So because again, that was pharmacists prescribing, DEA license, that's not what we do, at least in the state of Colorado. So that was a huge hurdle. So we had to shift our DEA 1 holder to one of our physicians. And then it's getting all of your staff able to, wrap their head around that they're doing a cannabis study. I will tell you, one of our patients, he looked at me and he said, when you were in pharmacy school, did you ever think that you would be counseling somebody on how to smoke weed? And I said, no. And he goes, and I never thought anybody would pay me to smoke weed either.
But wait, take us back. You have this theory. You're going to be comparing cannabis versus opioids for back pain. Is that right?
Yeah, correct.
So you have 2 arms, or is there a placebo?
There's a placebo arm as well.
Okay,
so we have
so
placebo,
3 arms.
oxy, and placebo.
Some patients are going to get opioids. Some patients are going to get cannabis, and some people are going to get a placebo for their back pain. Is that right?
It's actually crossover. So everybody will go through each arm. So at one point, they'll get one of the placebos and then active component. And then one visit, they'll get nothing.
Okay.
And then.
So each person is going to go through all 3, and they're going to have to rate their pain scale on the back pain, right?
Yes.
Okay. Now, who are the patients? Who signs up like, hey, I want to do some research on pot and my back pain? What are the patients? How do you get the patients, and what are they like?
So the patients have been great. A lot of them, they have the time that they can donate, right, for clinical research. Some of them feel compelled to contribute back, to clinical research. All of them have been recruited from our back pain or pain clinics at the university or, other back pain clinics. So everyone had to have, an MRI that said, yes, you've got this level of back pain or neck pain.
You mean MRI that shows disc disease or whatever?
Yes,
Okay.
exactly. So you have objective data. So not subjective, but objective data. And they have had this problem for a while. Some of them are on opioids and some of them are not. Those in that particular trial, those individuals had to come off of their opioids to come into this particular trial, or they had to have just a low level, so a low opioid dose to be admitted into the trial. So not people who are on super high doses. Obviously, you're not going to take them off and recruit them into a clinical trial. So,
okay, and so now you have how many patients?
I think we have about 75 patients, and we're just getting ready to close that study down. So we don't have any preliminary results at this time, but it will be interesting. And we actually induced some pain in the clinic. So we actually had a shin tester.
Oh, wait. This is fascinating. Okay, so you got 75 people, and now, let's pretend I was one of the patients. Take me through my experience.
So obviously we ask you a bunch of questions, right, for signing that consent form, letting them know exactly what we're doing. And then we do multiple levels of testing. So sobriety testing, if you were being pulled over and someone or the police officer wanted to know if you were consuming alcohol or another substance, could you complete these tests? So walk a straight line, touch your nose, balance issues, that sort of thing. So
But you know what, the thing that we learned from our DRE experts, our officers who do those testing, is impairment for alcohol, like walking a straight line, putting your finger on your nose, and impairment for marijuana is very different. Impairment for marijuana is not being able to remember things. Like people on marijuana can put their finger to their nose, but if you tell them, put your finger to your nose, scratch your head and turn around, it'll be like, okay, did you say scratch first or turn around first? Or like they cannot remember those simple instructions. It's a different type of impairment.
Right. At the time when this clinical trial started, we didn't really know that. So we would do the typical sobriety testing, but then we also do memory testing as well. So just as part of it, as part of all of the testing, and then we do use a machine that puts a pressure against your shin. So could you feel this? Is it a different feeling or sensation from one visit to the next?
So what is this? Is this crunching my shin?
It is. It's not crunching. That's a bad word. It's just putting a little pressure on the shin. So we actually had it built specific to this clinical trial. So very interesting. But
okay, so at first, I come into the clinic now, and I'm on my, and I don't know, right, whether I'm on opioid day, placebo day, or pot day, right?
Correct.
And I come in 3 different times for each of those things.
Yep.
And are you is this oral or vaped, or what is?
This is the volcanic vaporizer.
So what is that? Is that like like electronic cigarette?
No, it's actually, so it looks like a volcano, and then you put the plant material in a reservoir, and then you put a bag on top of that fills with vapor. So kind of like Jiffy Pop. Now I'm dating myself. It plumes up like a Jiffy Pop.
Would it work kind of like an albuterol inhaler?
Well, it's much larger. So volcanic vaporizer is big. It's pretty big. It's cumbersome, but it cranks up the spark. There's an electronic spark, and it heats the material to beyond 300 degrees so that it catches and burns and then turns into vapor. And then the patient consumes the vapor.
How do you do it? Is it through a pipe or?
No, you inhale. So you put a little connector onto the bag, and you have the patient breathe out and then breathe in, kind of like an inhaler.
Okay.
And then they hold their breath and they exhale. Now, when that,
So, all right. So I can see how patients are like, what do I do? Or do they know, like, hey, I got this, I know what to do?
a lot of them have it. A lot of them have used these in the past.
Okay.
Now, interestingly enough, so setting up for this clinical trial, we actually had to specify one room in the clinical trials area. It had to be HVAC, you have to be able to pull the vapor out or pull the smoke out or whatever you have. You have to be able to get that to the outside air. So that was very difficult, right? Very expensive to have that occur in our clinical trial research center, as well as where we store the product. That is also really expensive,
Cumbersome.
Yeah.
All right, so I figured out how to smoke it. Are most of your patients experienced cannabis users?
For
Is that why they
had to be.
signed up for the study?
Yes. But
Yeah.
now they had to abstain. So when they come in, we actually test them to see what we look for. We look for all different illicit.
Right. But I imagine that that's what causes bias and why, some trials fail, because you're selecting for people who have good experiences with cannabis.
Yes.
Right.
But some of them, it could be in the past. So it could have been 10 years ago. So
Right.
they don't have to be currently using.
Right.
So some of our patients actually have had negative.
Oh, and then do I do a drug test before I enter so you know that I'm really not using?
Yes.
Okay, so I take a drug test, I pass my drug test, I sign up for the study. Oh, am I getting paid?
Patients are getting paid. They're getting paid a little bit of money, not much.
Okay, so I get, that motivates
$50
to be good. All right, so smoke it. Then I wait how long before I do all the little testing?
So some of the testing, some of the serum concentrations, because we are doing serum concentrations, which is great because then we have more objective measures. But they have to wait like 15 minutes, a half an hour, an hour. So the patients are actually there for a long time, 6 hours in the clinic.
Okay. So then after smoking the product, did you say you draw blood?
Mm-hmm.
Okay, you draw blood and then you do all this, dancing and memory questions.
Yes.
Okay.
Yes.
And then you come in 3 different days. One day is the placebo, one day is an opioid, and one day is cannabis. And what potency are you comparing? Like how many milligrams of opioids smoked compared to how many milligrams of THC?
The oxy varies. So if you have taken a certain amount, clinically, that's what you were prescribed, then you move into a 10 milligram. If you're on, if not, you get 5 milligrams of oxy. And the cannabis is medium strength. So it's like 12, about 12%.
12%. So you compare 5 or 10 milligrams of oxycodone versus 5 or 10% of cannabis.
Yes.
All right. And then you do that with all your 75 people, and now you're in the process of collecting and analyzing the data. So you don't have a sense yet of what stood out.
No, not yet. Soon.
Right. Oh, and then wait, and then you squeeze my shin and then ask the questions?
Yes.
Okay. All right. Interesting. That sounds, the patient interaction sounds kind of fun.
Yeah, it usually is.
Now, all right, let's say you get the study for the back pain and you show that, cannabis works just as good as opioids. What does that mean in real life? Does that mean, okay, everybody, get more get more joints from the dispensary?
So what does that mean? It's going to be a good question. Obviously, if some people have had problems with opioids in the past, maybe cannabis is a better solution for them. If that were what ends up at the end of this particular trial, I can tell you.
But wait, Jackie, how can you say that when we spent so much time explaining how what you buy is night and day compared to what you get in the cannabis shops?
And I know, and that's very true. However, we do have a few places where we can reliably send patients that we do know exactly what's in the product. So they're more scientifically.
So tell me about those places.
So they actually do, have varying levels. They can extract their own products. They test it. They test for the heavy metals.
Is this a dispensary?
It's a dispensary. It is a dispensary, but it's more a dispensary-like. So it's more scientifically based dispensary. So there's not many of them. It's more expensive, but you do get the certificate of analysis. It's a real certificate of analysis, and they're more.
But is this a pot shop that sells all the little candies and the vapes and the dabs and the tinctures and the suppositories and all that, and then you can buy it? Does it look the same?
No, they usually only have a few products. So they might have a gel cap. Usually they don't have plant material. So they only have a few products available. So they're more specialized kind of thing.
Yeah, that's really hard for a doctor to do. Go to only this one shop in, I don't think that that's something that translates.
That's very difficult. So another clinical trial that is for autism, we actually give patients a list, of maybe like 8 places that do that they can get a comparable product to what they just received in the clinical trial.
Okay, so tell us a little bit about the autism trial.
Yeah. So
is that one completed? So do we know the data?
No, we don't. Nothing's really complete yet.
Oh, okay.
So we don't know the data, but it's for behavioral abnormalities.
Okay, so tell us about that one. That sounds interesting.
So that one is actually Epidiolex that we're looking at, and a placebo. And patients do cross over, and there's some patients that are on CBD the entire time. And
when you say they're on CBD, you don't mean the stuff that they're buying from the pot shops. You mean Epidiolex, right?
Epidiolex.
Okay.
Yes, correct. So
which is, again, way different, right? I mean, there was another study recently of that if people buy CBD from whatever Amazon dispensary, there's a high likelihood of having heavy metals and other things, and you don't really know what you're buying.
Exactly. Okay. Exactly.
But your trial is completely, from Jazz Pharmaceutical Epidiolex.
So it's FDA approved, it's purified, we know exactly.
Okay. So that's not controversial, right? And what does the autism study, you're taking young kids with autism?
Yes. So of varying ages. So I think up to 18 in that particular trial. And really looking and assessing their mood. So like aripiprazole, which is a traditional medication that also has a labeled indication for behavioral abnormalities in autism. So it's kind of mimicking what those clinical trials actually did to see if we can reproduce those results with Epidiolex or CBD.
Interesting. So what's also finding fascinating is there's a lot of studies that showed that THC can cause autism. That, moms and dads who are using marijuana and have conceive a baby, there's more likelihood to have autism in those kids. So now you're giving CBD, the antagonist of THC, to treat the autism that was potentially caused by the THC in the first place.
Yeah, maybe. We are giving them CBD that's purified. So different than what you get from a dispensary.
Right. Okay. So again, the thing that happens in our society, I have to warn, I even talked to Dr. Nora Wolkoff, who's like head of NIDA. When she says, or you say, oh, there's so much potential in cannabinoid research. It's like, yeah, I don't have a problem with that. That's great. That's how new drugs and new developments happen. But what people here, politicians here, and people on the street here is like, oh, okay, let me go to Amazon now and buy some CBD because it's good for my kids to have autism. And now they're giving CBD oil to children. And it's like, oh, no. Do you recommend giving CBD oil to children with autism?
No. No. And especially, again, if you're just going out and purchasing something from a dispensary and we don't have the results yet.
So I'm interesting that, the parents who have children with autism are probably desperate for solutions and why they participate in these trials. What's their attitude towards that? Do you feel like they're participating in these trials? They're very hopeful. They're proud of their participation. Are they going out to the store now and buying the CBD? Do they understand the difference?
They definitely understand the difference because that's one of the jobs that we have. So my fellows are also involved and more so involved with the patient level than I am. But they definitely make clear that difference. And again, at the end of that trial, we give them a list of dispensaries or these more scientifically based dispensaries where they could actually obtain a product that's similar to if their insurance company will not pay for Epidiolex. So no, we don't recommend going out and just going to any dispensary because then again, just as we mentioned, we don't know about the pesticides, the heavy metals, the contaminants in those products.
Wait a second. Is the issue that their insurance is not paying for Epidiolex and they have to pay out of pocket?
Yes. So a lot of times that is a big deterrent from getting the Epidiolex product. So they can get a prescription for it. Now making sure that it gets approved through prior authorization or whatnot, since it's not an indication.
I mean, it's a barrier, but my husband, my husband had a heart attack, stroke. He has a issue of lipoprotein A, and the insurance would not approve the Repatha, the drug that he needs to save his life. So am I going to go down to Mexico or buy it on the internet?
Yeah.
And maybe hurt him or live without it or pay?
Right. So right. If you can pay, that's what we recommend.
But if you can't pay, are people being said, well, I can't pay and my insurance won't have it, then they're buying potentially, arsenic.
Well, not if they're going to the places that.
So how do we know? How does a consumer know? How do parents know? How do people know how to go to a good spot?
So I think the first thing to do is to ask the provider. Most of the time, the providers are not going to know unless they're involved in the research.
Yeah, doctors don't know that. I don't know where to tell.
So they have to do a lot of the background research. So asking for those certificates of analysis, actually taking the product that they purchase and look for a number like an NDC number, but it's not an NDC number. So it's just a lot number that they have on the product, and go back to the website and look up that particular product to see what's in it. And we have our patients do that for when they're buying a CBD product over the counter. A lot of times, because it's an unregulated market, they find that there's a lot of THC in that particular product when they think they're just buying CBD.
Right. Right. And people ask me, do I see any CBD poisoning in the emergency department? I'll say, I used to say no, but now I think I do see people who come in with anxiety due to CBD. But I definitely see a lot of people who think that they're taking CBD and they test positive for THC.
Yeah, that's a huge problem. Huge.
Yeah. And then you're also doing, well, actually, all the things that you're doing is so interesting. What can you tell us about Parkinson's? Do any of your trials have results? Maybe I could ask it like that.
Our Parkinson, we did finish the results, and it was really found to not be better than placebo for Parkinson's tremor. Those individuals remained on their traditional medications for Parkinson's disease, and then they took this CBD product that I was compounding to see if their tremor got better. And it really, we did not have a positive result for that particular trial.
Did it have a negative result?
There were side effects that we saw, especially in that patient population, being more advanced age, on more medications.
Right. So many drug interactions, right?
Drug interactions, hepatic, liver function tests increasing. So we did, and GI was the main things that we found.
Nausea, vomiting, diarrhea.
Mm-hmm. And I will say that when our trial first started, patients were actually, our dose was too high. So we, after our data safety monitoring board reviewed the results, we lowered the dose of our CBD product.
So how do you feel as a researcher when a study kind of fails? So I think that I would say that bombed, like CBD and Parkinson's, like not a good idea. I mean,
at least for tremor.
And for tremor.
I think it's just as good to get those results out there as a positive.
Yes. I like to hear that you say that. I think that's very helpful. It's good to know what doesn't work.
Right. Oh, yeah, absolutely. And what the problems were.
Yeah. I think that's very helpful. And, yeah. So Parkinson's and what else? Multiple sclerosis, was that with THC?
That was Sativex, so GW Jazz, and those clinical trials have been put on hold because they did have negative results in some of their phase 3 trials. So, but it is licensed in many other countries. So it's a 1-to-1 CBD THC oral mucosal spray, and it does work fairly well for spasticity in some individuals with multiple sclerosis. However, I don't know what's going to happen with those clinical trials.
Wait, that's so fascinating because even the stuff published by the National Academy of Medicine says for multiple sclerosis, THC decreases your spasticity on a scale of 1 to 10, some small little amount. But they never add the part where, but people became suicidal or whatever the side effects were.
Right.
But and so was this trial for multiple sclerosis stopped? Was it kind of like the Rimonabant study?
No. And so basically, with Sativex, it was that some patients didn't reach a statistical significance on the Ashworth scale, so they didn't have a positive result with their spasticity on one of the measurements. So we weren't halted. We never actually started. So that's what they found from previous clinical trials. So it wasn't an emergency stop kind of thing, which we have seen in the past with other clinical trials, like you mentioned. So it wasn't statistically significantly positive. So they put the clinical trials on hold, the ones that were going to start up.
So the other really common symptoms patients or people use marijuana products for is insomnia, not being able to sleep. I've had, a lot of people tell me like, oh, I just take a gummy before bed. What's the science say on that?
Yeah, the science for insomnia is kind of interesting. So it looks more positive for CBD products than THC. THC, just like alcohol, it'll put you to sleep, but then you get up again. So you have a negative effect, which actually produces more of a habitual pattern. So you need to smoke more of the THC to go back to sleep. And then you see that cycle happening over and over again. So it looks like if anything is going to work for sleep, it's more positive on the CBD side. And it may be other minor cannabinoids. It might be a CBN that really is the product that is best for insomnia. But we need more clinical trials.
Wait, so what do you mean by that? When you're testing CBD, you're also including other cannabinoids, or how do you?
It just depends. So most of the clinical research that's out there for insomnia is more CBD, but there's some level of, just maybe little positive reportings that maybe it's a blend of CBD and CBN. So, I mean, we know that there are, so many chemical compounds in the whole.
And CBN is just another cannabinoid?
Cannabinoid, yes. So, and it's interesting because we don't know what all the cannabinoids do in the plants, and we know we have, a handful of them isolated, but we don't know exactly what they do.
So for your family, friends, relatives, colleagues who may come to you and say, hey, I can't sleep, what do you recommend? What do you recommend? As a pharmacist who does cannabinoid research.
Yeah. I don't recommend that. I don't recommend a cannabinoid, actually. Good sleep hygiene, melatonin. Yeah, there's a really nice product that I recommend to people, which is called Calm. So it's L-theanine and melatonin. For some.
Is that over the counter?
It's over the counter.
What's it called again?
Calm, CALM.
Okay.
Yeah, and it's like it's a powder, and
Right.
you just put it in hot water. So it works for some people.
Okay. But you don't recommend the gummies at night or CBD oil?
No, because I mean, that's a whole nother talk, right? So we know the bioavailability with the oral products. We have to be careful with that. So, and the way the gummies are made.
Again, talk to us about the gummies. Why do you not recommend gummies?
Well, so when the gummies are made, the gummies are preformed and then you inject, and it's usually THC that they're injecting. So it depends. I mean, there are some CBD ones as well, but again, you could be getting pocket effects. So if you only think you're going to take half, you might get the half with all the product in it, as opposed to half of the product. So it's just tricky. The dosing is tricky, and again, what product you're using is also, what do you use? What do you recommend?
So one of the questions I've been asked was, we know the flour is nearly 100% of the time you have the contaminants, the bacteria or the fungal. If you're eating it, and that product is made by the flour that has, E. coli and Aspergillus or Klebsiella, are you eating that bacteria, or is it cooked and you don't? It's boiled and you don't have that bacteria?
No, I'm not really sure. I think it's co-stays with the product, and it depends on how the product was extracted. So there's so many extraction methods out there. So some of it decarboxylated and some not. And some people are actually eating raw flour. So that's again a whole nother, another thing. And they may be getting some efficacy. So
the other research that you're doing, I thought was interesting, is psilocybin. That's getting a lot of press and states wanting to legalize it. What's science say on that?
Well, we just dosed our first patient with advanced cancer and mood changes. So we'll see how that goes. We're using 25 milligrams. It's synthetic. And we do.
Is it oral?
It is. It is. And we have also a placebo, with that particular trial. So it looks interesting. It looks promising, but it has to be, you really do need, to have somebody who knows what they're doing, watching the patient. So a trip watcher, so to speak. So someone in the room with the patient, in case there's a problem.
For how long?
Like 8 hours.
8 hours. That's a big thing. Watching the patient for 8 hours. And what are you measuring? Is it pain, anxiety?
So it's a lot of anxiety. You want them to have an experience. So it's going back to really, Native American or tribal, very ritualistic kind of thing. So you want them to be able to manage their pain better, manage their diagnosis better. However, there are adverse effects. So patients, nausea, vomiting, psychosis, all of those adverse effects we can see. So we're really hoping that patients have more of an acceptance, or a better acceptance, and able to deal with their diagnosis and their mood changes.
Interesting. My clinical experience, but I think it's also supported by research, is people who regularly use marijuana have a really hard time managing their pain. So people come into the trauma unit, or whatever, break their arm or have a laceration or have an abscess, whatever it is that's a painful thing. Their proportion of pain compared to other people with the same injury is much worse. They have a harder time managing their pain. They would need more opiates in dealing with that adversity.
Right. All of that.
Yeah. So psilocybin, you're using it again. I'm probably asking you the same thing several times, but I just want to make clear, people are listening. It's psilocybin. It's you're using it for cancer patients. Should you now make it legal because people are using it for cancer and it could help cancer patients? So shouldn't we legalize it?
Well, in Colorado, the Wild Wild West, as you are also in the Wild Wild West, we do have decriminalized psilocybin laws. So in Denver, not every suburb, you can have a certain amount of psilocybin on your person. So I don't think it's a great idea because, again, there can be adverse effects. Is someone going to get on top of a building if they're having a bad trip and jump off, think they can fly, all of those things? There are those people. That is going to happen. So, and no, I don't think it should be legalized. I think, let's see what the science tells us. Let's go with that. Let's see what the science tells us and make determinants based on science.
Yeah. At the Johnny's Ambassadors Conference, what Laura Sachs held in Colorado, one of the speakers had a slide of the Wright brothers plane. And the plane showed that, propeller not in the right place and the wheels not in the right place and, all the engineering. And it's like, really, do we want to make a fleet of these airplanes before the science and technology? We really put the cart before the horse.
And I think we've done that actually a bit.
Yeah. So conclusions. What's your advice as a researcher?
I think that research should be a little easier to do good science, to produce good science. And I think that consumers should know that what we're using in our clinical trials is really not the same as you can get from a dispensary, because you don't know exactly what you're getting, what you're really putting in your body. So in terms of the research side, I wish it was a little bit easier, a little less red tape, but I understand it. The universities get federal funding, and so you can't compromise other federal funding for using a Schedule I product.
If you could fix the whole situation, what would you do?
Just to have more companies like, BRC, biopharmaceutical research company. So just to have more companies that have gone through all of the paperwork to get their products, selected and their company selected, and knowing that what they're producing is really what they're producing, so that we have more options for clinical trials, more product options.
So that's great. I definitely support research, support the FDA process of keeping us safe, and being transparent about warnings and advice to patients, whether it's a medicine or you're getting whatever stuff from dispensaries. People should have the right to know about what's in their products and the side effects that they may be experiencing. I want to say thank you to Shay. Thank you so much for your question and your cheerfulness in the emergency department. You have a great career ahead of you. And Jackie Bainbridge, thank you so much for the research that you do, for joining us, bringing us high truths, and bringing us. You actually do bring high truths in your science.
Thank you for having me. It's been a pleasure and lovely meeting you.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support of our sponsor. A sincere and warm thank you to Isaac, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit isaac1.org, that's IASIC1.org, to view their library that translates medical journals for public understanding, listen to their speaker series, and follow the science on marijuana. High Truth producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more high truths.